Uh, Good afternoon, everyone. I'd like to welcome everyone out, both our members and our guests, to today's event sponsored by Houston Compensation and Benefits. I'm Matthew Griffith. I am the program director for Comp and Ben, and I work as a compensation practitioner for Cristy Inc., a global natural gas company. One purpose of Houston Comp and Ben is to provide an avenue to exchange information among our members. And one way we do this is by offering programs like the one today. In planning the calendar year for events, we thought it would be better to share information before professionals start their initial review of programs and finalize those decisions. We initially scheduled this benefit-related program in the summer, but we thought it might be better if we were able to provide insight before those final decisions were made and be too late in the process. With that in mind, we moved this topic to the spring. So thank you for joining us for this benefits-related panel discussion entitled Employer-Built Healthcare, a different approach to delivering on your promise. As a reminder, towards the end of our discussion, we will have a Q&A. Please use the chat feature and direct your questions to Karina Davis, who has helped us organize our event today. As I stated before, I am a compensation practitioner and have just a small exposure to benefits, particularly healthcare insurance. I asked my boss, who's led the HR function at several companies for almost 2 decades, about the process of selecting the right healthcare plan for employees. And so from that, I have learned that understanding the costs, where the costs come from, and designing the plan to meet those needs, all the employee is paramount, and setting the right plan or plans. Also, the use of a third-party support is important in those decision making, either by a broker or by consulting services. Healthcare expense can be the third most, could be a top 3 expense for most companies. Healthcare continues to rise, with legislation trying to help improve it. The healthcare is also known for hidden and surprising billing. It exposes companies' employees to financial risk. Almost 2/3 of all personal bankruptcies are for healthcare-related reasons, and for those, 70% still have healthcare insurance. So before I introduce our panelists, I'd like to share a short topical video on healthcare developed by one of our panelists. Mike?
There are no prices on anything here.
Oh, believe me, some of it's pretty spendy. Whoa, that's really gone up.
Stop. I don't need both, just one or the other. It depends on the price.
Oh, that's called shopping. We don't do that here. Thank you for coming in. Your bill? Your version will be mailed to you in 30 days. Good luck trying to make some sense of it.
So as you can tell, I think a lot of it's wondering why healthcare has to be this way. Why are prices not known before I even receive them? So our panelists have definitely learned the same thing and have been inspired to change healthcare in their roles. I'd like to introduce each of them of our panelists today. We have Mike Andrade, who's based in the Houston area as the lead advisor for BenefitU. Carl Schuessler, who's based in Georgia and is the co-founder and managing principal at Mitigate Partners. And last but not least, Cristy Gupton, who's located in North Carolina and is the president of Custom Benefit Solutions. Each of them is passionate about healthcare. And so I'd like to offer them to introduce themselves and share what and why they're passionate about healthcare and how they use that to help and advise their clients. Cristy?
Sure. Thank you for having me with you today. It's truly an honor to speak about the inertia and the excitement around improving the healthcare experience for employees, and then having that automatic byproduct being lower costs for employers. employers are truly struggling with the cost of healthcare. Small businesses are failing to thrive because of the cost, and even large employers are having to make difficult decisions around what they're going to fund and what they're not going to fund at the drastic increase in the cost of healthcare. And in our blocks of business, we don't see that happening. So we would just like to tell the world that there is hope. So thanks for joining us today.
Thank you, Carl.
Sure, Carl Schuessler with the Managing Principal and Population Health Manager, Mitigate Partners. It's an honor to be here with you guys today. My personal journey got started back in 2013 in February after I had been jacked in the face with a baseball and had 6 bones in my face broken. I was reading Time Magazine, Stephen Brill's Bitter Pill article at the time was the longest article in Time Magazine history. And I jumped and kind of went down a journey that took me all over the world to try to find the best cost containment and risk mitigation solutions that were out there. And it's culminated over a 7-year journey into what we call the Fair Cost Health Plan. So we believe in employer-built healthcare versus the traditional, we feel archaic, insurer-built healthcare that has ceased to meet the needs of employees and the employers. So we went a different route and built an employer-built plan.
And Mike.
Yes, sir. By the way, Matthew, you're doing a great job. Thank you so much for all that you've done to prepare for this. And just to echo the sentiments of both Cristy and Carl, it's an honor to be here. And I love the fact that I get the opportunity to speak to you. My story started probably in late 2016. Now, I know many of the people on this call, and I've been in this industry since 1993, but what changed for me is where I would call what activation is. In 2016, my wife and I were on a trip in the Bahamas. She was not able to keep her food in at all. We thought it might be the resort. We thought it might be sensitivity to gluten. But when we came back, she had a battery of tests, and lo and behold, my wife was diagnosed with cancer. And it's not just any cancer, it's a very rare form of cancer that both Steve Jobs and Aretha Franklin had. And I thought, you know what? I've been in the healthcare space for eons. I'm equipped to help my wife navigate the healthcare system. And what I found was that everything I was trained about, knowing about great discounts and knowing about the price of healthcare that you can find on a website or calling customer service, all of that stuff failed. And so my why is every employer that's out there has a Tracy on their team, somebody that's struggling through healthcare. And me, having the experience that I do, realizing that I didn't quite have the tools, my mission and my why is to make sure that those Tracies that are out there can get the right healthcare, the right diagnosis as soon as possible, so that they can live as normal of a life possible. Now, when you meet my wife, don't treat her like she's sick, because she's amazing. But that is what drives me, is how do I help the Tracies on your team? Because if we can do that, we can lower the price of healthcare just by improving the quality and access to professionals and guiding people through that process.
Thank you for joining us. As you can tell, each of our panelists are very passionate about helping everyone with their healthcare plans and helping and create the quality healthcare in that matter. If you look at a pie chart of where the dollar of healthcare goes, almost just over 25% actually goes to the direct provider and personnel to provide that healthcare. So you can see that there's a lot of some of it might be waste, some of it might just be overhead. So there's sometimes it just doesn't seem to work. So Carl, I know you have strong feelings, as you said, about traditional healthcare providers. Can you provide your thoughts on that?
Sure. I think, Matthew, I've often said, and I know many others have said it, so I certainly won't take credit for this quote, but healthcare is broken. Healthcare isn't broken. It was made this way. And that statement speaks volumes. It isn't broken. It was absolutely made this way on purpose. My father was a 40-year OBGYN. in the system in private practice. I watched the world change for him in the late 80s and early 90s when managed care intruded. And there's no question about it when you look at it. And hear me on this. I don't fault insurance companies, pharmacy benefit managers, PBMs, hospitals, to physicians, or to brokers. We're not brokers, we're advisors, but a lot of folks are brokers. And when you look at that, most of those organizations are delivering to their number one priority, their number one fiduciary responsibility, which is to the shareholder. So if you own stock in those companies, you're loving life. But the problem with it is the employers on the other end and the employees are on the other end. And therefore, when those misaligned incentives drive stock price, they generally have passed down a lot of costs to everyone in America. And that's why you've had wage freezes and many other things. And basically what employers have done is raise their deductibles and their out-of-pockets yearly, making the benefits worse and charging more money and passing the cost on to their employees. And it's had to do to combat this. So we saw the misaligned incentives, and it's real simple. You eliminate the middles, disintermediate the system, as Dr. Keith Smith, surgeon center in Oklahoma, always says. And if you do that, you can fix this. And we've done this numerous cases. And I think the misaligned incentives is the biggest part, Matthew. That's the biggest problem. And we need to put the patient back in the center of healthcare. And right now, they're not. And our programs that Cristy, Mike, and I work on to Mitigate Partners, we put them back in the center, and that member really gets the care they need without the counterproductive barriers and communication issues you have to deal with in the traditional, more insurance environment.
Yeah, and Carl, what I would add to that is, and Matthew, you even brought up in your introduction about government intervention. And then you have to ask yourself the question, can government fix healthcare? And also ask the question, can health insurance fix healthcare? And what's interesting is that when you look back, think back to March 23rd, 2010. Does everybody remember what they were doing? That happens to be my birthday, and I'm not saying that to get everyone to sing happy birthday to me, but it's more along the lines of that's when the Affordable Care Act was passed. And hence the main word affordable. You would think that the cost of the price of those stocks for companies that their primary industry is health insurance would have been affected tremendously. And they have been tremendously. It's not really, if you look at the impact of those stock performance prices since March 23rd, 2010, compared to the S&P 500, the S&P has gone up about 250% since that date. And you look at the average performance, it's about 3 times that for health insurance companies. So if you ask the question, can government fix healthcare? Just look at what's happening in Medicare, and you can argue that it's not. But then when you look at the stock performance, health insurance companies, they don't have a problem because, as Carl said, they're beholden to their shareholders, and they're doing exactly what they need to deliver on their promise.
Yeah, I like that image, that visual image of the dollar, and how much of that dollar actually goes to pay for patient care. And, it's even smaller than the 25% that you mentioned. It's about 8 cents on every dollar that actually pays the doctor. And so the way the dollar is spent in our status quo healthcare system, it has done more to separate doctors and patients from each other than to bring them together so that they can truly work, together for the better health of the patient. So a lot of what we do intentionally tries to pay more of that dollar to the actual doctor. Imagine that. So that the doctor has the ability to treat the patient deeper in a more holistic way. We always talk about how doctors and patients need to be brought back together. But if you're only going to do it in a 7.5-minute stint of time, then, don't bother. Okay. Let's bring the doctor and the patient back together, but in a quality amount of interaction so that the patient actually has a fighting chance of getting better instead of just drifting into worse and worse state of health.
And Matthew, I know that the intent of our discussion today is to talk purely more about the foundations of employer-built health. But I just want to say there's probably 4 things. Now, if you've all heard of a guy named Marty McCary, world-renowned physician, but also a huge advocate of fairness in pricing. What he outlines in his book, The Price We Pay, is essentially there's 4 areas in healthcare that if we can address those 4 areas, we can solve a lot of the problems. First is being overcharged. Now, RAND recently released the study, the RAND group, and I don't know if you all listened to the Houston Comp and Benefits presentation last month about it, but they did a comparison of what commercial insurers are paying relative to what Medicare is paying in Houston. So for hospitals, so inpatient and outpatient, which represents anywhere from 50 to 60% of your total spend, the average carrier, the markup is 250% of Medicare. Now that's crazy. What's even more crazy is that you really can't tell when you have to go into the healthcare system who has a better price. It's very difficult. So dealing with fair pricing, dealing with opaque pricing, and then there's a notion of being overtreated. Now, Johns Hopkins University did a survey a few years back, and they just asked their physicians, how much of your treatment is unnecessary? What's the waste in healthcare? And they estimated about 21% of the services that they render really are irrelevant. Other studies indicate that it could be as high as 50%. Now, I want to take a step back and say, okay, if you look at how much we spend as a country on healthcare, it's $3.7 trillion. I know we spent more than that in the last 6 months on other areas, but just say 20 to 50% of that is waste. How much is that? That's a lot of money. If you break that down into actual dollars, it's essentially half of the economy of Texas. That's amazing. Now, take it back to your plan. You could have 100 employees, 1,000 employees, 10,000. What would you do with that 20 to 50% in value that you could find by being more efficient with your healthcare dollars? So, those are generally the things that we see. I'm not sure, Cristy and Carl, if you have anything else you want to add to that, but.
I was just going to say, I tried to get that number on my phone. It won't even go that high.
Yeah, it's a lot. That's just an estimate.
I will add one other quick thing. My personal perspective in this whole healthcare crisis is very different than most. Growing up at the dinner table, hearing about C-sections and deliveries and all other kinds of terms I'll leave out here. I watched my father, how the practice of medicine changed. And I'll never forget, he told me, son, it's going to be real bad for your kids and maybe even yourself as we go. And once it used to be my doctor, my choice. I'm picking Dr. Andrade because he's the best, not because he's in the network. I'll never forget when my dad was sitting there one day, Cristy Gupton, for example, was a patient. And she came in and said, Dr. Schuessler, I really enjoy, working with you, and I appreciate delivering my 3 babies and da-da-da-da-da. But I'm going to have to change doctors because you're not in my network. And my dad his practice decided not to participate in networks. He's a pretty principled fellow like us. I guess that's where I get that from him. But he decided not to participate in networks. And when that happened, these patients started to leave. And he just couldn't believe it because they only had to pay X amount to come in with a copay with managed care. And they chose to follow the network, even though he had 20+ year relationships with many of these patients. So I think when you look, we have a picture we're not going to show you, but Healthcare Simplified, you've got a doctor looking through the third party, could be insurance companies, PBMs, whoever, looking through the ear of the third party, and the third party's looking in the ear of the patient. So it's a real problem, and I can tell you from living it and watching it, it's absolutely real. And that's why my father had to see 20 to 30 patients a day just to cover his overhead and his ridiculous malpractice insurance from delivering babies, like $150,000 a year. So it's a real problem, and I apologize. I'm pretty passionate. I've been pretty calm so far, so I'll stop there.
And Matt, the last thing I wanted to say is that, a very huge element is the variation in quality. There's a website called surgeonratings.org. I think they might have changed their name to Checkbook, but they published an article about a year or two ago, just looking at the quality variation in Houston alone. And they used heart surgery as an example. And if you looked at the top 10% performing doctors versus the bottom 10% performing doctors, there was almost a 400% increase in the death rate based on that quality difference. And what's interesting is within how we consume healthcare now, quality is very important, price is very important, but there's no correlation between price and quality. And as consumers, it's really difficult for us to navigate quality because it's not something we shop for every day. And so part of the solution as we get into it is how do we marry those elements into an employer-built solution that allows for shopping to happen, but also uses cost, quality, and a bunch of other cost containment components to allow flexibility of choice, but definitely using price and quality as part of the equation.
Thank you, Mike. That kind of brings us to the main title of our topic today of employer-built healthcare. And Carl would like to, what does that look like, Carl? How does employer healthcare look like?
Well, it's a great question, Matthew. What we were seeing again is every year we were delivering rate increases to our clients, costs were going up, and it was very frustrating. And so, like I said, we went a different direction. And so what we tried to do is literally deconstructed the entire system, the healthcare system, and rebuilt it brick by brick. And we layered the bricks that we call cost containment risk mitigation components together. And we started with the foundation being direct primary care or advanced direct primary care, value-based primary care, whatever you want to call it, is the foundation, and getting it back to the Marcus Welby MD days, neighbors taking care of neighbors, a real relationship with a physician. And so we started there, and then we layered the bricks on top, and we went and found the best bricks we could do. And when we brought them together, 16 plus senior solutions into this employer-built plan we call Fair Cost Health Plan, that's what we were charged with. And it allows the employer to actively manage their health plan. And the traditional model today, the insurer-built healthcare, is more passively managed. And again, is managed by groups that the more they save you goes the inverse opposite of their stock price. So it's very difficult for them to help control the costs as well as we've been able to do with our clients.
Carl and Matthew, Carl, you mentioned the foundation of primary care, and I'd like Cristy to talk a little bit about her experience with direct primary care. And the reason I bring that up is that in an open access network, primary care, it's crucially important, but it's kind of underscored as maybe just you call your doctor when you have an urgent situation or something like that. Now, I'll tell you in another study that I read, the importance of primary care to hospital systems is tremendous. And the reason for that is every primary care doctor is worth about $8 million a year in referrals. When I first started in the business, the entire networks were constructed of independent physician offices. And now the consolidation is rolled up to where most hospital systems have their own physician network. And a big part of that is that the referrals into the healthcare system represent a ton of money. It's kind of like going into a convenience store to buy groceries. But that amount of money is pretty profound. And so, Cristy, could you talk a little bit about direct primary care, your experience with it, and how it influences outcomes?
Sure. And I just want to go back to what you just mentioned about private equity owned or hospital system owned primary care. So, like Carl mentioned, back in the good old days when it was feasible to be an independent doctor, and you made the money that you made and you served the patients that you served. And then after the Affordable Care Act was passed on your birthday, Michael, it really it set up a financially incentivized environment for hospitals to buy the then struggling independent primary care practices. Because in the time from when Carl's dad retired through to the time when the Affordable Care Act was passed, insurance companies learned that they could squeeze those independent primary care doctors and squeeze and squeeze and squeeze them. And then all of a sudden, the Affordable Care Act gave the hospitals a way to come in and save them, right? Oh, we can save you from that. We'll just buy you. You'll just become part of the hospital. But what they forgot to tell those doctors is that now you're going to have requirements on how many ortho consults you send, how many MRIs you order, how many of this drug or that drug you prescribe. And so then it became a very perverse system. So let's just say I went into one of those practices that just got bought by the hospital, and maybe they had great new renovations. Maybe they even had marble countertops in the bathrooms. But when I get in the exam room with the doctor and I just simply make one simple complaint about my knee hurts, oh, well, okay, well, let's order an MRI and I'm going to go ahead and refer you to the orthopedic surgeon that is just on the next block. And you know where it goes from there. And so that was the system that was set up, and we still have it today. And you just referenced it in the number of dollars that represents. So in direct primary care, these are the doctors that have opened their doors and hung a shingle and said, I'm not taking insurance. I'm just taking patients. I'm just taking people who need me, and I'm willing to work with you on a membership basis. So if you can afford my $65 a month, for example, monthly membership, then I'll treat you like you were one of my family. Right. And so they have the ability to limit their patient panel. The national average is somewhere between 500 and 600 patients per DPC doctor. And in comparison, the hospital-owned doctors, primary care doctors, carry a load of about 4,000 to 6,000 patients on a national average. That's a very big difference. You know, I'm in a membership-based model with my direct primary care, and he has intentionally limited his panel to 500 patients. So at any given point in time, if I text him, email him, call him, want to do a video chat, or just simply show up without an appointment at his brick and mortar office, I am welcome to do that. I don't have to wait in a waiting room. I don't have to wait on a waiting list. It's almost like it's not concierge medicine. I know there's a big misconception about that, but I will attest to the fact that it's a concierge level experience as a patient to be able to be served on the spur of the moment as needed. It creates such a positive user experience, as well as all that downstream stuff that would have ended up in MRI orders and consult orders and referrals and prescription pads being pulled out and written, you know, for a number of different prescriptions, even opioids. So, you know, it's just a whole different world. The outcome of the savings, the reduction in the downstream spend is huge. And that's what I think that employers ought to look into. If we narrowed our recommended network, you know, for primary care to a doctor that was able to give our employees 24/7 care, how would that change the after effects of how care is consumed and paid for? And so those are the kind of stories that we like to tell, and the kind of fundamentals that we like to incorporate into the plans we design.
Hey, Cristy, can I piggyback on what you just said?
Please.
There's a very famous, arguably one of the top DPC doctors in the country, Dr. Lee Gross. He practices on the Southwest Gulf Coast of Florida. And he had introduced us to a hospital client we're working with that has been featured all over, actually in the Texas legislature, Matthew, where you live, in Austin. About a year ago, we discussed it in the legislature. And the interesting thing that I would share with you about Dr. Gross is he was a fee-for-service internist. And one of my other clients is not far from him. It's a hotel, a resort, where the CFO used to go to that practice when they were fee-for-service. And so I'll be quick. It's tough for a Southerner to be fast, but I'll try. So the funny part about it was when I told Glenn, the CFO, about we were using the Dr. Gross with the hospital, with direct primary care, he said, Carl, every time I went in to see them, they always referred me to a specialist. And I quit going to them. And that was under their old model. And that's why they left that model. We're doing EMR, doing all the reports, all the stuff to the insurance companies. That's why they left. So the point was, the doctors are not the bad guys here, folks. They're put in a system by the whole managed care world. And that's, a lot of them have been some that could escape. If you're an OBGYN, I think it's a little tougher. If you're orthopod, it might be tougher too. But when you're a primary care doctor, there's a better path. And I just think that speaks volumes. When I told Glenn that, that's what he said. I said, well, that's not how they work anymore. So there's a whole come full circle for you.
Yeah, and what I would offer in this conversation, y'all, Cristy, apologize, but if you've not heard of a man named Dave Chase, pick up a copy of his book, The CEO's Guide to Restoring the American Dream. And there's a lot of information that's in there. But one of the things that's interesting that he talks about is when you look at the cost of healthcare versus somebody that's in a hospital-built system, versus somebody that has an independent physician, the cost of healthcare tends to be about 60% higher for those that are affiliated with a major healthcare system. And I would just offer, ask your doctor the next time you go to see him or her, hey, do you know, when he or she gives you a referral, ask if he knows how much it's going to cost, or ask if he knows the quality of the physician he's sending you to. And I asked my doctor about 3 or 4 years ago how he chooses who to refer. And he says, well, Mike, what I do first is I find out if they have good insurance or not. If they have good insurance, I'm going to keep them within our healthcare system. If they don't, I will work with them and try to find a non, I won't say the name of the system, but a non-system provider. And so he was the only doctor I've talked to that had a sense of what cost was. But the reason why you want to consider primary care as an employer is because that is the entry point into the healthcare system and can have a significant impact in the total cost of the downstream of healthcare. Most direct primary care doctors can handle 80 to 85% of all things that affect you in our lives. The main difference, or one of the main differences in addition to that, is when they send you somewhere else, they know the price, they know the quality, and they're more often than not going to send you to somebody that already accepts cash up front. And when we talk about cash pricing a little bit later, that's a huge benefit to you as a plan sponsor. Go ahead, Cristy.
I was just going to say that in my groups, we call direct primary care your personal physician on speed dial. And so there's not an insurance company on the planet that gives you your own personal physician on speed dial. So if your employer can construct what an insurance company cannot, then it kind of begs the question, why do you need that insurance company?
Yeah, so I would say that part of the challenge for you as an employer, Matthew, you and I talked about this in our early, like, well, we're an employer in Houston and we might have employees outside of the city of Houston. And so our recommendation is that one, consider breaking apart your plan and really reconstructing it to where you use many of the point solutions that can lead to lower cost, more effective care. But then also as it pertains to primary care, the answer is going to be different to everybody, depending on the unique footprint that you have as an employer. But definitely beg the question as you go through your renewal strategy and how to incorporate that. It's like, where does DPC fit within our plan? Can we incorporate some of the elements of DPC? Or if we have people that are spread out throughout the country, how do we use primary care as a way and a wedge to help with some of the downstream effects from referrals? And then also, how do you use your third-party administrator to help also incentivize or direct folks to the right place, using quality first and foremost and price as part of the equation?
One more closing comment on DPC, and we can move on. I hope everybody understands direct primary care, because I think I sure do. We have a hospital client. that put in direct primary care, and I want you to say, I want to say that one more time, a hospital client. A hospital owns physicians. They put in direct primary care? Are you kidding me? And so through another relationship we had, we introduced Dr. Gross, who brought us into this hospital. And in the first year, the hospital saved 1.2 million or 54%. And where we can beat our chest and say, hey, this great plan that we employer built, fair cost plan is wonderful. That's great. I have to give a lot of credit to Dr. Lee Gross and Dr. Crouch for managing that population. And the results of that, glad to share it, are unbelievable to everything Cristy and Mike said. I don't have to tell you, but all of a sudden, you've got a population taking care of themselves. And that's a very more socioeconomic challenged area, fourth poorest county in the state of Florida. So huge difference.
And don't forget, Carl, to send everybody to the page to either Mitigate Partners YouTube channel or the patientsrightsadvocate.org. You can hear DeSoto Memorial Hospital's employees tell it in their own words. An employee tells the good story that she was able to get from diagnosis to treatment in a few short weeks. And, you know, that's really not a story that many people can tell out there in a land where everything is controlled by insurance companies.
What are some alternative healthcare models that we have that we can really help us cut costs and help really provide better healthcare for everyone? Carl?
What are some alternative models?
I would offer, in terms of some of the solutions, it's what are some things that we can do to essentially improve the price of healthcare without cutting plan design. And so, do you mind if I take that?
Yeah, go ahead, Mike. Go ahead.
Yeah, so what I was going to offer, there's two things that I would suggest. Now, mind you, there's a lot more than that, but we don't have the time to go through it. So I'm going to suggest two things, and then I'm Cristy and Carl to suggest a couple of things. Now, first, it's using the concept of free, using the concept of a financial incentive to build a promise to your employees. Now, I call these smart shopper options. I didn't coin that phrase, but I just like it because what it does is it implies a promise to employees. It's like, hey, if you do something, you pick up the phone when the doctor says go down the hall. If you pick up the phone or the phone rings and it's your third-party administrator, take the call. Because chances are good, if they talk to you about the quality and price, if you follow their recommendation, that service is either free to you or it's a reduced cost. Now, why is that important? In that when you look at the Memorial Hermann as a great example, I don't mean to pick on them at all, but they just happen to publish their prices online right now. If you look at the price of a knee surgery for Memorial Hermann, it's about $20,000 downtown. That's with insurance. Now, if you show up with just a bucket of cash, it's about a third of the price. You can also go to the Oklahoma Surgery Center. They post their prices online. That price for the same surgery is going to be about $5,000. You pay them up front and you're good to go. Now, why as a plan would you want to give employees a financial incentive of free? Waive their deductible? Well, would you rather pay that $5,000 price or the $20,000 price for the same surgery? So I would offer that you as an employer really should consider how do you integrate free or smart shopper options into your plan. The second thing I'd like to say is that I might tell a story about my wife and I. When we travel, we have a timeshare and it's Hilton Grand Vacations. And the first thing we do when we get to wherever we're going to go is we talk to the concierge. Now, the unique thing about Hilton Grand Vacations is that all of the experiences that you can sell, so you do some type of excursion, they have a very high quality standard that you must adhere to if you're one of their providers. And so the reason we do that is the value we get from going to the concierge is we know we're going to have a great experience every time. That's the value we have to us. And so the combination of free plus a concierge with somebody who knows quality and price and knows the experience that you want, that is a game changer for you as a plan to be able to direct traffic and create a better experience than your employees may be getting right now. So I'll turn it over to Carl or Cristy to talk about a couple other things.
Chris, you want me to go or you want to go?
You go ahead. I'll go last.
Well, ladies first, jump in there.
Okay. Okay. So yes, real life story. Very much like that. In a plan that I designed in Asheville, North Carolina, a restaurant group with about 100 employees. The first procedure of the plan year. So they hired me in a certain month. The contract was effective, the first of another month, and then within 2 months after that, an employee slipped skiing, tore the ACL, and there you go. We've got our first procedure we have to deal with. So we've done the work of teaching the employees, you need to start with your direct primary care doctor first. And so this employee heard that and followed that advice and started with the DPC first. So the direct primary care doctor did the assessment of the knee, emailed me right away and said, I think we're going to have a referral. It looks like it needs to be surgically repaired, but hey, I'm just the primary guy. But catching that before it went just arbitrarily to the hospital or arbitrarily referred to any old orthopedic surgeon is the sort of the magic sauce. So the moral of the story, or to kind of wrap up a long story and make it short, we ended up being able to buy a very high quality from an absolute expert, a top class surgeon who performs that particular procedure. And we were able to buy it, pay for it, totally bundled and guaranteed for $9,000 out of the plan's assets, as opposed to what would have been about $35,000 if it had just gone to the hospital. So when the third party administrator called the employee to let her know we'd done this research and here are her options, her comment was, "Oh my gosh, I didn't even know insurance did this. This is great. So yeah, I'll go to that one." And it was a very, almost a picture perfect scenario. She was back to work in record time, and it couldn't have been better. So I don't want employers to think that when we call it employer built healthcare, that they've got to do all the work or it's going to change their workload a ton. We, as the advisors, as the experts, we set up the channels to make this a well-oiled machine, but the outcomes are superb, no doubt about it.
From a cost and quality standpoint, I think just a quick, I'll go back to the my dad well one more time. I worked at a golf course growing up, and I was probably in my teenage years, and I'd ask my dad, I said, "Dad, I won't say the doctor's name, Dr. Golf." They called him Dr. Golf. Dr. Golf is always at the golf course. He's a solo practice OBGYN. I don't know how much y'all know about OBGYNs, but if you're a solo practice OBGYN, you're on call every day. There's no break. My dad was in with one partner. My dad was on call every other day, every night, miss Christmas, whatever, because they alternated. And I said, "Dad, how can Dr. Golf always be out here? You got 4 partners and you're never on the golf course." And he said, "Son, his C-section rate's 50% and mine's 15. Now, Matthew, I don't know about you, but wouldn't you want to know that your wife's going to get cut open 50% of the time before you go versus 15% of the time over here?" So that information, what Mike said, the hospital transparency, patient rights advocate, Cynthia Fisher, Laurie, all of them are doing a wonderful job. But hospital transparency is the first step. But you've got to get the quality. The quality is what matters. And that's the biggest decision. And normally, price and quality are inverse opposites in healthcare. And everything else, you get what you pay for. Not in healthcare. Normally, the best quality providers are the lowest cost. But you never know that. And so it's important that you know that. Or Cristy's getting knee replacement. Does Cristy want to go to a doctor that does it 4 times a year or a doctor that does it 60 times a year? That's the kind of stuff that the public can't get their hands on. My dad knew that back in 1982. My memory's right. And you're going to challenge me that I don't really know it was 1982. It was 1982. And he knew that because he had access to that data. So it's really, really important that the plan, we call it weaponizing or incentivizing the plan design. The critical thing that has to be done is your plan has to be incentivized and steered to the right place. And that's done by employer-built healthcare and designing a plan.
Thank you so much, everyone. This has been a great discussion for us. I think, or I guess we'll wait. I think a few questions are coming through, and
So Matthew, what I wanted to offer is that, we've talked a lot about some of the things that are broken in healthcare. We talked about direct primary care. And we've talked a little bit about how that can help in navigation. Now, Carl mentioned an employer-built model, which essentially is the foundation of primary care. And all of those components, as you build a custom house, you build those bricks, and all of those bricks essentially are held together by each other, and they're also anchored by a very capable third-party administrator. Now, you probably have people on this call that are saying, that doesn't fit for me, or I don't know what to do about any of this just yet. We either love the carrier relationship we have now or not. But I would offer that as part of your ongoing strategy. I tell people all the time that regardless of what business you're in, if you offer healthcare to your employees, you're in the healthcare business. And you owe it to yourself and owe it to your employees to figure out how and what you could do to improve access, improve quality. And if you can focus on quality and price, if you focus on price and quality, the cost of healthcare tends to take care of itself. Now, part of the challenge is as you think about how most people on this call are probably oriented with a carrier where everything is under one shop, from soup to nuts. It's everything from administration to pharmacy benefit management to contracting with the hospitals to medical management and clinical management. Our experience is that when you break each of those components apart and you have an employer that's activated, they're leaning into healthcare, saying, okay, how can I challenge each one of these to construct something that fits for me? Then the magic happens. And I call that activation. I'm sure Cristy and Carl call it something else. But the point and the message I want to leave to you as an employer is that wherever you're at right now, think about where you want to go. And it doesn't necessarily mean you jump off the boat right now into an active management like plan that we're talking about now. Just really, what are the elements that you could collect wins from right now and use that to build on future successes. Now, we haven't talked about some of the noise that comes with the transition away from a traditional carrier, and that certainly does happen. But I just want to make sure the point resonates that we're not advocating that everybody jump off the ship that they're on right now. You've got to figure out a solution in the direction that's right for you and as a part of your long-term healthcare management and benefit strategy.
So what has been how have carriers reacted when a DCP plan has been introduced by employers? How does it work when you kind of bundle those together as two employees?
Well, don't expect your carrier to give you any credit for it. So I would hire an expert on how to help you design a program where you do get credit for that good decision. Well, Carl, what's your cliche? You can't expect employees to make the right decisions unless, I don't remember your saying, but you have a saying for it. You have to incentivize good decisions.
Plan designs must reward good decisions.
Thank you. Plan designs must reward good decisions. And I'll tell you, with a client that hired me, they had already sort of dipped their toes in the direct primary care waters, but their prior broker hadn't adequately explained the potential of direct primary care. It's like their employees were thinking of it as a minute clinic or some kind of last resort. However, when I was able to sort of change their thinking, and I used that your personal physician on speed dial cliche, it sort of changed their whole claims outlook. And so immediately specialist visits started going down, urgent care visits went down drastically, and obviously other things, lab costs started going down, prescription costs started going down. So what we did was just sort of change the thinking. If you start with this doctor first for everything, then everything else that comes after it will come to you easier and at less, less of a cost. So from a plan design perspective, please don't rely on your carrier to welcome direct primary care with open arms. And please don't expect them to lower your costs, even though they're going to pay out lower claims.
And Junaid, hey bud, it's good to see you online. He asked a question: is the DPC like a carve out of primary care from the carriers network? How do carriers respond when an employer puts DPC for their PCP visits? And I would offer, Junaid, that it's really that answer is going to depend on how big your plan is, where your people are located. And so for you and for anybody else, it's really that's the starting point. I would say that if you're in a model where you control all of the rules, meaning that you've built the plan, you've chosen the third-party administrator, PBM, and all of that, the integration is a lot easier because you start with primary care as a foundation. And then the DPC doctor, in conjunction with the third-party administrator, help each other when it comes to downstream referrals, prescriptions, and all of that. In a traditional Blue Cross United Cigna world, that's really going to depend on how you set it up with your employees. You could easily set up a DPC within your plan, and it may not be attributed directly to the health insurance product at all, but they can work together. And that if you have a membership-based program, you can send your folks to that directly. And then when it comes to referrals, that DPC practice will just have to know how to work within your plan using either whatever carrier you have now as part of the referral process.
Yeah. When you're in a fully insured model, folks, DPC is good. You're not going to get any, as Cristy said, any premium reduction credit from the insurance company. If you're in a, we call BUCA, Blue United Cigna, Humana, BUCA, or Insure Bill plan, it's probably going to be hard to get a lot of credit there too. It's much more complicated in that world than it is when you move away from that world more into an employer bill plan. It can work. And you can also put other solutions in alongside the insurer bill plans, but it's a lot more difficult to really get to the end game, which is improving member outcomes and improving your financial outcomes as well.
Okay, so I'm going to throw this question to Carl and Cristy. Junaid asked, what's been your experience with year-on-year cost savings after an employer implements DPC?
Yeah, again, draw the start comparison. If you leave a BUCA network in place and you leave your big insurance carrier logo on your ID card and maybe they're paying your claims, you're not going to see much, if anything. However, if you adopt a more independent model like employer-built healthcare, like what we're talking about, I'd give it at least 20%, something like that. And usually, like Carl said, there are probably other deliverables that are being stacked up besides direct primary care. And actually, Junaid's question, it is relative to DPC. So, one thing that you want to track, if you're not able, or you just can't fathom the idea yet of moving away from a carrier-driven model of a big insurance company, I would at the very least implement some kind of account-based, tax-advantaged bolt-on at the front end of claims, like an HRA or a MERP or something like that, so that you have your own leverage against your carrier. So when it comes time to renew and they want to pull your loss ratio is 100 and something % over last year, at least you'll have your own little data set at the front end of the claim cycle that you can use as leverage against that argument. And that could probably help you if you partner that up with direct primary care, but you just can't leave an insurance company built plan just yet. At least that's one baby step that you might consider. But I'm of course, as people can probably demise at this point, that surmise, excuse me for using the wrong word, they can surmise by this point that I'm not a real big fan of insurer built healthcare.
If
Wow.
anybody wants to dig around and learn more about DPC, probably the easiest guide is a book by a good friend of Cristy and I's, Dr. Shane Purcell, Magic, Pixie Dust, and Miracles. There's a lot of good information in there from what you can expect from our side of the table, a broker or an advisor, and what you can expect in the employer market. It's a really good book. It's called Magic, Pixie Dust, and Miracles by Dr. Shane Purcell.
I would offer one thing in this question as well, as Janae, as we're talking about the employer built plan, direct primary care is a component of that. Now, when we look at savings across the board, generally 15 to 40% is a pretty good number to assume when you put many of those components together. But if you also consider there's a local doctor, First Primary Care, Dr. Goyle, somebody you probably want to talk to. He and I have worked together, and last time we talked about the impact that he's had, looking at an impact of a population, it was about a year over year. So comparing the same experience year over year from open network to direct primary care, it's about a 40 to 60% with the same population impact. And so the outcome can be profound when it comes to that. But I also want to make sure the point's clear that it's additional components to build the plan to make it perform according to your needs and your employees' needs.
Thank you, everyone. I guess what type of employer, what is the profile of an employer that kind of would want to approach this alternative idea of healthcare? I'll open up to anyone that would like to start.
You say it best, Cristy, so go ahead.
No, I think any employer of any size can do something that's alternative to the current status quo. For instance, I am an employer. I have a small business. I only have myself and 5 other people, but I'm the only one who needs benefits. All of my other colleagues are over 65. They're my seasoned professionals, I call them. And since I'm the only one, I stayed for many years. To my great regret, I stayed on my husband's health insurance that was run by a big insurance carrier in my state. And more often than not, I ended up in urgent care. We ended up consuming care that we didn't need, didn't want, and didn't want to have to pay extra for, but we did it. And finally, last year, I moved and adopted a direct primary care relationship. And then I chose a health sharing organization called Sedera. It's a Texas-based company. You could look it up. And that is now my healthcare combination, direct primary care plus health sharing. So I'm essentially a business where only one person needs benefits, and that's how I chose to pick an alternative. And I can promise you, I have never in 25 years had better healthcare than I have today. And I promise you, never go back to paying insurance premiums to a big insurance company. Let's take that on the other side of the spectrum. Large employers can do nearly anything they want to, but they can still construct employer-built healthcare with all of these components that lower the cost as much as it does through using self-funding. And the middle-sized employers can still use the principles of self-funding, but they can take a hybrid of it, use a level funded plan. So there's lots of different options. It can go from one employee all the way up to unlimited employees.
I think, Matthew, to tie it to numbers of employees, I mean, you can self-insure all the way down to 5 if you want to, if your cash flow is good. But I would say normally 100 plus employers to really look at moving towards this model we're describing of a really fully employer built. And then the other biggest decision is their financials and their cash flow. And that's a whole nother discussion, but not everyone can be self-funded because you pay the claims as they come in. Some people like to know that I owe, Buka 20 grand this month and 20 grand next month and 20 grand the month thereafter versus 100 grand, 10, 200 grand. So, uneven cash flow. So that's a big decision part two. But with this model that we have built, we will help contain your cost and hopefully cut those fluctuations down. Can I take a second and explain one more thing? Because I want to make sure that everyone out there is crystal clear on this. When we say employer built, we talk about it in the form of a house, and each brick is a cost containment solution. So let's name just a couple of them. A cost and quality guidance navigation that Cristy and Mike have discussed. A RX pharmacy optimization block to help get the right PBM contracts if you use the PBM. A medical management firm. That's extremely important. It really starts with medical management. I can go on and on this one, but when you find out, like we did with one of our clients, a $3.2 million heart transplant in March of last year, and that's the first we heard of it. And then because of the Buca discount, it's 2.2 million. Thanks a lot. That's great. And then if we had that call in our model, all of our partners will have worked together, all hands on deck. All these bricks are integrated in a platform where they communicate in a HIPAA compliant platform. And we would have been able to get the heart transplant for $184,000 paid up front. And that would have saved that particular client. It was a $900,000 stop loss policy. So it cost them and the taxpayers $900,000. That's what we're talking about, is not being done in the insurer built model. These bricks working together, reviewing medical bills. 99% of all bills coming from facilities have errors. It's just a fact, and we can back it up. I can back up my story, my wife, for $29,000, $984 laparoscopic appendectomy, $10,694 in billing errors, 40% of the bill. I can show it. Many people around the country seen that up on the screen. So it's the bricks working together in unison. We're the conductor of the orchestra, and we found the best flutist and the best violinist. And that's, as an employer, that will enable your cost to stay down and save money. And one last thing, everyone throws out, and it just irritates me to no end, reference-based pricing is the panacea to everything. Reference-based pricing is a blunt instrument. It's very difficult to start a relationship with a provider or a facility in an antagonistic manner that way. There's a lot better ways to do that in a model that we work with. So I think that's important. That's the answer. The healthcare cost equation, and leave you with this, is real simple. Cost equals utilization, how much your people are using healthcare, and the price of care. That's it. And you have to influence those two pieces in the equation to bring it down.
Thank you so much for everyone joining us today. I'd like to thank our panelists today. It's just been a great discussion. I hope this was able to provide a lot of new ideas to everyone who was able to join us today. Hopefully we can, hopefully this will kind of provide you another nugget as you discuss your healthcare plans going forward for this year. And as you saw it early on the slide, we have our next program is on May 20th. It's going to be at the Junior League. It's going to, hopefully we'll do it in person as we transition away from Zoom, as we can transition, as we try to gather safely. So we'll have a great topic. It'll be the topic of executive compensation. Kind of give you a heads up, and we'll kind of expand on that. So thank you to our guests, and thank you for joining us. And now this will conclude our presentation. Thank you.
Thank you.
Thank you.
Bye.